very good evening to all. It's been an honor on behalf of Marengo Asia family and all the guest dignitaries who are present here to invite Dr. George Velmahos for the first Marengo Asia Oration Lecture. This is a thought which we decided during the journey that over a period of time, we will reach a stage, we'll invite the best of the minds who have dedicated their life and their commitment for elevating the standards of care in trauma and acute care. As we started interacting around 1.5 years back, maybe 2 years, I found there are a lot of people with a lot of degrees. There are people who are educated, more or less, few degrees more, few degrees less. But behind those degrees, somebody who should be given this honor to give oration, you have to have a fine human being. There has to be heart of gold person who is actually trying to give back to the society. And we started interacting. Dr. George told me a long time back, and he said, I've been trying to figure out, and by the way, he was to meet the Greek Prime Minister a few days back, but he basically said that I'll still make a trip for this conference because I love this so much and I would love to be in India. So his point was, last few years, I've been trying to figure out how do I shape and bring that kind of concept in my own country, that's Greece. But world over, when we discussed with a lot of people, nobody has been able to get the handle around this concept of trauma and acute care. That's the time when we decided that let's actually put this thought together. Let's try to create a platform, and we will have people like him who will come and give this lecture, which will enlighten us and give us some guidelines on how do we move forward. For those who are academically interested, I would just like to read few aspects more than which go beyond. So he's received his medical degree and doctorate from Athens, as I said, from Greece. He also has master's in medical education from University of South California, and is fellow of American College of Surgeons, American College of Critical Care Medicine. He's also done masters in Royal College of Surgeons of Edinburgh and Glasgow, highly educated person. He is John F. Burke Professor of Surgery at Harvard Medical School, Chief of Trauma Emergency Surgery and Surgical Critical Care Units at Mass General Hospital in Boston. He is a trauma program leader for setting up of Center of Integrated Medicine and Innovative Technology, the founder of Center of Early Trauma Research at Mass Generals. He is also the honorary professor at University in Johannesburg and in Greece, and I'm sure that somewhere down the line you'll find as honorary professor in some Indian universities, including for us. We look towards learning from you, my dear sir. He is recipient of multiple awards. The list can go on. I do not want to take the thunder from his lecture, and I would say that once you hear him, you'll fall in love with him, the passion with which and the teacher he is. Once again, a round of applause to Dr. George Velmahos.
Good afternoon. I have to fight postprandial state, post-masala chai state, post-coffee state. And for this, I need to first express my profound appreciation for involving us, not just myself, but all of us from Boston, to your beautiful country, and to this very profound custom-changing, practice-changing conference. And above all, I want to thank the architect of all this endeavor, the person who can think above and beyond what most of us can think about, Dr. Rajiv Singhal, because without him, none of this would happen. I intend to not produce too many data, and I would be, now I have an even higher level of anxiety to perform because I am in front of one of your most renowned producers. I understand that Mr. Hirani, who's here, is honoring us with his presence. And although I do not intend to try to attract him to recruit me for an actor's career after my surgical career, I do intend to educate him about trauma because he's in a very, very powerful position to maybe through his skills educate the nation about the importance of trauma. I had an elaborate title on the conference brochure, but I synopsized it, I summarized it in this title, because this is exactly, Mr. Hirani, what trauma is. It happens in a blink of an eye. None of us expects that we will walk out of this building and our car will crash, we will slip and fall, we will break our head, we will tear our kidney or our spleen, and then we will be stuck in traffic with an ambulance that is desperately firing off its sirens, and we will not make it alive to a hospital. Or if we make it alive to the hospital, it will be the wrong hospital without the right infrastructure, and we will die there. Or even worse, we will remain incapacitated for life. None of us expects that. But this happens in a blink of an eye. And I will start my narrative. Again, I'm not going to tire you with statistics and a lot of data because you've heard it all. I'm almost embarrassed to continue on the wonderful lectures that you heard from my American and my Indian colleagues. So I will try to tell you a story. What happened in America, how the whole thing evolved is like a story. And what were the challenges, how we evolved. I'll tell you a story. First, three very common stories. One of them, I shared it with you last year. You know, a happy family dinner, which 3 hours later results in a catastrophe. And these people have two options: either to arrive expeditiously within the golden hour with the right way to the appropriate place of care and live intact, or die. This is a good friend of mine that allowed me to show her in national and international audiences because she makes a profound example of what an organized system can do. She was 28 years old, right out of law school, a young lawyer, when going back at 7 p.m. to her house from work, she got crashed by a drunk driver. She was ejected from the window of her car and landed on a fence. She received exactly what you see, and I apologize for the non-medical personnel for the graphic nature of the slides, but she landed on the fence, her gut hanging out of her body, her muscles of her anterior abdomen completely destroyed. She was immediately brought to our trauma center, immediately operated. This woman, who you now see her giving radio and TV conferences with me, is now not only a successful lawyer, but also a yoga instructor, flexing her muscles, placing strength on her muscles, full of rigor and youth and life, a person that would otherwise, in many other countries of the world, would deserve to die. And this is obviously the epitome of good organization, which we in Boston always take particular care, pride about, even if it is now nearly 14 years after it happened. The great celebration that we had with the Boston Marathon, you see the bombs exploding on the right upper corner of the slide. And again, I've told you before that if it could happen in Boston, a city of education, a city of healthcare, a city of peace, a city of intellect, not a city of money and untoward competition, but a city of peace. If that could happen in Boston, it could happen everywhere. It could happen to Delhi, it could happen to Bombay, it could happen to Kolkata, it could happen everywhere. And an organized system had the power of convert the terror that happened on nearly 300 injured patients, again, in a blink of an eye, who were immediately transferred to hospitals with macerated legs, with shrapnels in their heart, with injuries to their pelvis. This system had the power of converting by its organization, by collaboration, by the ability of doctors to work together. You see here a trauma surgeon, an orthopedic surgeon, a plastic surgeon, and a burn surgeon, all four together working on the same patient. This system had the power of creating citizens who were again functional to society. Because this is actually my greatest argument to politicians. I say, I do understand the need to create transplant systems. I totally understand that. And I totally respect my colleagues who treat cancer, who treat failed livers, who treat, in the United States anyway, 75-year-old alcoholics with cirrhotic livers who get a liver transplant. I totally respect that. It's very much needed. I hope when I am 75 years old with a failed liver, I'm not drinking, that somebody will fix me. But trauma is a self-sustaining system. If you fix these 30-year-olds, because it's mostly 30-year-olds who get injured because they live with high-risk behaviors, if you fix them, they will come back to society alive, well, intact, and they will be able to produce back and give back to society the amount of money that society spent on them. It's a closed circle with trauma, except that the government that spends the millions of dollars now in trauma may not see it within this government's lifetime, but if somebody has a far-reaching goal, then trauma is a closed system. So what is trauma, Mr. Hirani and staff? What is trauma? Trauma is not this. A lot of people think that when we talk about trauma, we talk about PTSD and emotional trauma. Yes, it is obviously an element of psychological issues, but for the most part, trauma means physiological injury, insult to our organs, to our flesh, to our body, and the way we treat it. And it all started in America. It is it is an eye-opening story. Yes, it did start in the 60s with this revolutionary report, which a country like America that was spending millions, billions of dollars in healthcare, you probably know that we spent 22% of our GDP in healthcare when every sane country in this world spends about 8 and 12% of the GDP, right? In 1966, a groundbreaking report from the National Academy of Sciences put trauma in the center, and for the first time said that trauma is a disease and we need to change it. But it wasn't the report. It wasn't the report. It was a one-person's story. Can you believe that? That a system changed because of a one-person story? This is how systems change. They change by the passion, by the wisdom, by the energy, by the efficiency of one person that can move the needle and can make a system change. And this person was an orthopedic surgeon. Back then, surgeons were rich. He was in 1976. and he was driving his personal little plane to a wedding in Los Angeles, actually San Diego, I think, in California. And then after the wedding, he flew back to his house in Nebraska. That was in 1976. And under low clouds, he lost orientation, and over the plains of Nebraska, he crashed his plane. He was there driving the plane with his wife and his 4 children. His wife died immediately. His 4 children were heavily injured, except of his son, who only suffered arm fractures, and himself, the driver of the plane, the pilot, who suffered the least amount of injuries. He extracted everybody from the ruins, and there he started his struggle trying to bring his people, his own relatives, his own children, to a place of safety from the plains of Nebraska in sub-zero temperatures to a point of care. And he couldn't do it in America in 1976. He went from hospital to hospital after he literally stopped a car on the street full of blood. You can imagine the scene in the middle of the night. And then they went from hospital to hospital, and they couldn't receive care. And eventually they arrived to a hospital and they were saved, all of them. And he went to the American College of Surgeons. He had contacts, and he said, this can no longer happen. We have to create a system by which myself and my children and my wife and my family and my friends can be saved from a random accident. And this is what the American College of Surgeons, they bought into it, and they started creating things, and this is how we created this wonderful document that now has undergone multiple iterations, and we created a whole system of trauma hospitals, of trauma teams, of trauma processes, of trauma protocols that are all regulated at the federal level, and then with state level orientations through this document that is called Resources for Optimal Care of the Injured Patient by the Committee on Trauma of the American College of Surgeons. And after that, numerous courses to educate the nation to speak a common language. And you can imagine back then how much resistance we found. How much resistance, not we, but my forefathers, how much resistance there was, for example, from well-meaning general surgeons. He said, what is the big deal about a splenectomy? I can do a splenectomy. Why do you need specially trained trauma surgeons to do a splenectomy? Well, I keep on saying, it's not about the act of surgery. It is not about the act of surgery. I do not do oncologic surgery. You know why? Not because I cannot take a right colon, not because I cannot do a right hemicolectomy. Of course I can, but I do not have connections to the chemotherapy department, to the radiology department. I don't speak the same language with them. I don't read all the literature about the new chemotherapeutic agents. I do not. I am not an oncologic surgeon, despite being technically adequate to do a little colectomy. Same thing about trauma surgery. You are not a trauma surgeon because you can do a splenectomy. You are not a trauma surgeon because you can pack the liver. You are not. You're not because you don't frequent in the emergency room, you don't speak the same ATLS language, you do not know the grade of liver injury, you do not. And this is the essence of knowing something in depth. This is the classical article that actually was placed before by previous speaker on the board, but this is one of the greatest statisticians, trauma statisticians if you want, in America, that showed that all the money that was invested in trauma for so many years really worked. And because this is small print, this says that patients who go to trauma centers and are managed by specialized expert teams, compared to those patients who go to non-trauma centers, carry a 25% better mortality. Trauma center versus non-trauma center, 7.6% versus 9.5%. And actually, if you if you measure those patients who have the highest level of injury, then the difference becomes 30% versus 43% mortality. So this is 30% more survival. What it means in plain language, it means that out of every 3 patients, one who was destined to die will survive because this patient will arrive at the trauma center. Can you imagine the huge impact that exists? This is not about 3% and 5% and 7% mortality improvement, as most studies do in modern medicine. This is about 1 out of every 3 patients who would otherwise die will now survive because we have an organized trauma system in the United States of America. And the new focus is to arrive to a state of preventable deaths that approach 0. I don't know whether it's realistic or not, but this is the vision of the future. I want you to realize that whether you're young or old, trauma can happen to everybody, whether it's blunt, whether it's a motor vehicle crash, or a fall, or a slip, or interpersonal violence, it can happen to everybody. But you have probably seen this slide and the slides that I'm going to quickly throw here many times. Since 2009, the statistic hasn't changed. Across the world, trauma is the #1 death between ages of 1 and 44. So I'm going to shock you with what I'm about to say. I hope you're not shocked. But if your children and grandchildren are ever going to die, they're not going to die of cancer. They will not going to die out of inflammatory bowel disease. They will not die because of allergies. They will die because of trauma. Your children and your grandchildren. And you see the scale of a problem, particularly in the developing world, right? HIV, AIDS, TB, and malaria together are dwarfed by people who die from trauma. We throw all the dollars in these infectious diseases because we think that particularly in middle and low income countries, this is what kills people. Well, it's not. It is not. People don't die. Yes, of course they die of TB and malaria and HIV, but they die mostly from trauma. And the tip of the iceberg there, this is one of the countries in Europe, by the way, Mr. Mitchell, it is, the deaths are only the tip of the iceberg. For every dead person, there are thousands more that will never be able to give back to society because they will be permanently disabled because they weren't really part of a good trauma system. Particularly in low and middle income countries, and you've heard especially all the data from India that were much better described by the previous speakers. This road traffic accidents is a national tragedy, is a natural epidemic. And obviously, whether it is the Western world, which you see here, where trauma is only surpassed by heart conditions, or it is middle and low income countries, where trauma is actually above everything else. The financial burden to these countries is huge because of trauma. And you see the tragedy here, the slide that I showed you before with research data interposed, that whereas we recognize that trauma is the #1 killer of all these people, in terms of research dollars, where do we put our scientific minds to advance the future, to create new methodologies, new medications, new interventions? You see that in HIV, AIDS, TB, and malaria, we'll put about 50 times more research dollars than in the area where our countries suffer and where young people are killed by. The saddest thing is that don't think that trauma is going away. Yes, absolutely. If you speak to your politicians, they will absolutely tell you, and they're right, that they've created better road systems, that they've taken preventive measures, that they do what they can do. But all the predictions are that trauma will continue to increase in all areas of the world, in the war-ridden areas of the world, and in the peaceful areas of the world, we will be seeing more trauma and more traumatic deaths as time goes by. And with that, I want to kind of end the trauma story about how trauma evolved in the United States. This is a very, very strong trauma system that we have in the United States. I do think that this is a model of in the world, not to transpose the American reality into India, Greece, Tanzania, or wherever else in this world, but to get the methodology, to get the principles, and in a certain degree to get the passion and the understanding of what trauma means for our countries and to create trauma systems in the world. But that didn't remain without challenge. And trauma became a challenge. You know why? Trauma specialty became a challenge, and we had forces in America that led to change, a change that I think will be extremely relevant to India. So I ask for your attention for a minute. Dr. Paranjape talked about that. Dr. Salim talked about that. But I ask for your attention because I do think that this is extremely relevant for India. There were changes from physicians, from patients, and from the healthcare system to create a structural change in the way we're delivering trauma care. And this is the physician side. It's very important. The new generation was not becoming trauma surgeons. When I was young, I remember, I always wanted to become a cardiac surgeon. I finished medical school and I wanted to become like Christian Barnard in South Africa, who was my idol back then. I wanted to become a trauma surgeon. Then I did the first trauma operation of my life. I went into a trauma center in South Africa for the first time in my life, and I fell in love. It was love at first sight. I never looked back. I became a trauma surgeon. But now the new generation is not doing that. The new generation was not doing that. Why? These are studies, older studies, but they remain even more relevant today. In the University of California, San Diego Trauma Center, from 20% penetrating volume, the penetrating volume, which is predominantly operative, fell to 10%. And in the University of Louisville in Kentucky, from 72 operative blunt trauma, now with new methodologies, we only operate half. And we are all surgeons because we love to cut. We love to cut. That's why we're surgeons. We love to operate. And if we cannot operate, then we're not going to go to an operative specialty just to babysit patients for other specialties. So the physicians were saying, we see decrease in operative volumes. Why do you want me to go and become a surgeon when the operative volumes with the new methodology, embolization, non-operative management, all this, why should I become, there are a number of reasons why people didn't want to go to trauma surgery anymore, but the most important one was the decrease in operative volume. So the physicians were forcing a change in America. The patient side was one that I have been saying for a long time. I was literally less than 30 years old, and at the University of Southern California, I had a very, very famous chairman, a very famous leader. And I was telling him, Dr. DeMeester, I do not understand for the life of me why, when we have a trauma patient at a push of a button in this best trauma system in the world, 20 people are around this trauma patient. They come from everywhere. And blood bank is being reserved. ICU beds are being reserved. Operating rooms are getting ready. All type of specialties know about this patient. We provide amazing care. Next door is a patient with perforated gastric ulcer. You know what this patient gets with full peritonitis and sepsis? A phone call at 3 a.m. A phone call by a junior physician to some surgeon who's at home. This surgeon wakes up, says, is he dying right now? No, he's not dying. Okay, well, give him antibiotics and I'll cancel my elective list tomorrow and I'll do him first thing tomorrow. That's the care that these patients were receiving. So if you were shot in the chest, you would get all these trauma teams, protocols, you name it. If you had necrotizing soft tissue infection following an operation, we would get nothing. If you were happy enough to have your pelvis broken, you would receive the trauma team. If you had, on the other hand, ischemic colitis, you would get nobody. If you were lucky enough to be stabbed in the abdomen with your gut hanging out, you would get everything in America. If you had ischemic bowel, you would be operated after 10 hours and you would be dead by then. So all these things made the push from the patient side that we need a change. And then it was the healthcare system side, which you've heard, and I don't think that it's that relevant to India, not yet anyway, but in the United States, essentially forced by the public pressurizes people to subspecialize. You know what, quite frankly? If I have a problem, I do not want a general surgeon. Quite frankly, if I have thyroid cancer, I want to go to a person who does thyroid cancers every day of her life. I don't want to go to somebody who does 2 colectomies, 2 thyroids every month, 1 stomach, 1 liver, a little bit of everything and nothing really good. I want to go to the expert. So everybody would subspecialize, which means who would be at night there that would have the broad knowledge to fix everybody who comes at night with a variety of problems, right? So the ERs were not getting the appropriate doctors, we didn't have the appropriate outcomes, and emergency surgical care in America was suffering. And you know, it was like you would wait for hours, you wouldn't receive appropriate care, and there was time for a change. So I described how trauma became a very interesting system, a very powerful system, only to realize that those with non-traumatic but similarly devastating surgical emergencies, they were not receiving good care, and it was time for a change. And this time changed when we created a new specialty about 20 years ago, 18 years ago, where we included trauma, emergency surgery, and surgical critical care in one specialty, and we called this specialty Acute Care Surgery. So for the public nowadays in the United States, I am not a trauma surgeon, I am an acute care surgeon. And we wrote back then in 2007 with my good friend Jerry Jerkovich a vision about how we think that the future should come when we transform trauma surgery to this new specialty that will treat all surgical emergencies of traumatic and non-traumatic nature, and will transition even in the ICUs to provide continuity of care to these very, very sick patients. And the Committee of Trauma, the National Society, created a committee in which both Dr. Salim and I have participated, and we created an educational pathway and a fellowship pathway, and we remained with multiple challenges. I cannot tell you all the challenges, but the most important challenge, well, again, the general surgeons, right? And you have plenty of general surgeons in your country, and they will say, what is acute care surgery? What is acute care surgery? I put bread on the table by doing perforated duodenal ulcers, by removing ischemic colons, by treating bleeding problems. To me, emergency surgery is defined by these 4 words: bleeding, obstruction, perforation, and acute inflammation. Anybody who has any of these 4 words deserves an acute care surgery, because they are there, at least I'm talking about the United States, they're expert, they're dedicated, they're 24/7 in the hospital, they have critical care credentials, they can manage complex disease, and they have this feeling of urgency. That was the entire point of our training, of our education. Everything is urgent. And when we looked scientifically to what did it do to our general surgery colleagues, because we were with the deepest respect to our general surgery elective surgeons, we wanted to make sure that we do not constrict their practice, we do not eliminate the bread that they put on their table for their families. We saw that in institutions that created acute care surgery services 2 years before versus 2 years after an acute care surgery service was created, the operations of the acute care surgery group, of course, increased. The operations of the elective surgeons did not decrease because their elective volume increased now that they were not constrained in the middle of the night or during the weekends, staying sleepless to treat all these emergency surgery patients, but they could focus on their elective practices. And again, on another article here, you see how trauma versus general surgery, they both increased volumes and revenues. But the most important thing for me came here. Remember I told you that trauma was not a desirable destination for training for surgeons, and we were losing our clientele. Who would be those surgeons who would take care of me when I am injured? Who would be they? Nobody, because they wouldn't come. And now with this change that we created for trauma to acute care surgery, surgical volume improved, revenues improved, outcomes improved, everything improved. The young generation of medical students suddenly saw a very desirable goal, a very desirable target for their training. And after orthopedic surgery, the second most desirable training for young medical students became trauma and acute care surgery. And when we asked them why, look why. Because this is what our specialty is. Our specialty is full of intellectual challenge. Every day I go in the hospital, I see something new. There's not one patient like another. They obey general principles, but every acute emergency surgery patient has a unique profile, and that provides intellectual challenge. The reward of life-saving interventions. Absolutely, you should treat with liver transplantation this 75 years old. And you will give this 75-year-old another 5 or 6 years of life. But a 25-year-old trauma patient will give you the satisfaction that you saved a young life that will live there and give back to society what society gave back to the patient, gave to the patient. The technical demand of doing very complex operations and the diversity of practice, but of course we lost in predictable work hours and minimal. So with that, I want to finish and accept that it is not simple. I know that as you're looking at me, I hope that you understand the passion. I hope that you understand the vision of building something that can save a lot of young Indians, a lot of young Saudis, a lot of young people in our countries, and older people, of course. It's not just young people. And I do understand that it's not simple. I do understand that it will need powerful collaborations between the public sector that will have to create legal processes and the private sector, which in my mind is the only efficient way to not be bundled up by the government, but to be able, with visionary people, to move forward. It will need this collaboration. It's not going to be simple. You will find a lot of resistance, a lot of hurdles, but this is something that you need to do, because the best way to predict your future is to create it, and I think this is very, very true for India. Thank you very much. Mr. Irani, are we ready to create a film about that? We have to talk.
Thank you very much, Dr. Velmahos. I would like to ask you a question. You are coming from one of the most advanced trauma center in the world. I would like to ask you a question. Do you have any audited data from the injury to first medical contact time and from the injury to getting the patient to your trauma center? Average time.
I'm sorry,
do you have any audited data?
What are the data?
You have got any audited data that will tell you what is the time between the injury and first medical contact, and between injury and patient arriving in the hospital?
The times, the pre-hospital times.
Yeah.
In Boston, there are 6 minutes.
6 minutes, okay.
6 minutes, yes. I was yesterday, we were driving through high traffic, no surprise to anybody, and there was an ambulance behind me. I timed it. It was with the sirens on, with the lights on, and I don't know, they must have been transferring some critical patient, I guess. They were behind me for 12 minutes, like the highway was packed. They were behind me for 12 minutes, and finally they went around us and stayed like 2 cars ahead of us for another 12. There were like 12 minutes stuck in the traffic. This ambulance would arrive in a hospital in an hour. I mean, the game is lost.
I know the average time in India at this point of time is 30 to 90 minutes. Depends whether you are urban or rural. My point I want to make is I would like to congratulate and thank Dr. Rajiv Singhal a lot. I've been a trauma surgeon, now I'm a knee surgeon. The biggest problem what we are facing here is basically, you go to any part of the world. I worked in England, I worked in Switzerland, I worked in the United States, I still go as a visiting faculty to Stanford. But one thing is very common. You find expert doctors, you find a place where there is no Indian doctor who is there as an expert. So there are everywhere. So the point is, India does not lack the talent. India, in fact, export the talent. I was a leader of a trauma team in my young days in the United Kingdom for 3 years. I attended so many trauma calls, helicopter emergencies. The biggest problem which I find that Dr. Singhal can probably address and the government can address is, if you say HEMS, Helicopter Emergency Medical Services. If you compare United States, there are 1,000 helicopters who are integrated in medical services. In Europe, there are 900 helicopters. In India, there's only one. And government is appointing another 50. So the point is, as you very rightly mentioned, it is responsibility of the public and the private and public partnership to take this forward. So this is going to be a first cornerstone to start this sort of services. And I'm sure you would agree with me that the most important thing is for Indian patient is to reach in time to trauma center. We have got good trauma centers, there are good skills there as well. It's only present point of time, the most important thing to be addressed is this.
Thank you.
Thank you. That was a fascinating presentation. Thank you very much. I really like the way you brought it up and the role of acute general surgeons who are managing trauma and other acute phases. That's how we have built up our system in Bristol. One question. There was something about reducing surgical volumes. And I feel that, yes, we are all experts in trauma. Prevention is better than cure. If we can have less trauma, it's always better for patients. And where do we focus? Of course, we need to solve. Trauma will not go away. But where should the focus be primarily? How much is prevention of trauma also of importance?
The trauma surgeons and the acute care surgeons in general, they have a primary responsibility to create prevention and actually to participate in prevention. And actually the American College of Surgeons, when it reviews trauma centers, the prevention efforts of this trauma center in its local community take central role. So we offer our expertise in prevention. Having said that, we shouldn't be the only ones. And obviously I cannot change the road system in India. If I were an Indian trauma surgeon, I would love to participate in a committee of the government to offer my credible opinions, but I cannot change. So yes, prevention is important, but the role of the trauma surgeon is mostly in-hospital care and to contribute in prevention, not to lead it. People may have different ideas.
Any questions from the audience? Usually we don't ask the oration during oration, but I think that the topic is so interesting. And if somebody wants to share something or have comment or ask George from experience, a couple of questions are more than welcome. Anybody from the audience, if they would like to ask. Still people mesmerized, but anything, yeah, I can see Richard. Yeah, Richard. Can somebody pass on the mic to Richard, please?
I want to hear from Kyrgyzstan too. And Saudi Arabia. There, Dr. Mashbari, you have to tell us about Saudi Arabia too.
George, that was an incredible talk. Thank you so much really inspirational in the way you presented it, and as colleagues have said, full of really useful, thought-provoking information. 2 points to the question, if I may. One is a personal one and one's about your presentation. So the first bit is you spent sort of 24 hours in your company. You're an inspirational person. What keeps you going despite the many challenges that you and your team will encounter every single day? And then a point you've made a couple of times, and I think it was in one of your slides, about the investment in trauma services compared to HIV, cancer, etc. Why do you think there is this underinvestment in trauma services, and is there anything we can do about that?
Because for the most part, thank you, Richard. And by the way, our 24 hours of interaction put me in awe of what you and your chief nurse are doing there. This is an amazing system that you run in Leicester. I think it's just lack of advocacy, like everything else. You know, when HIV came to the world and it became a national epidemic, an international epidemic, there were very passionate people who talked about HIV. And that's how Bill Gates decided to throw a few $1 billion into treating HIV in Africa. For trauma, there was no advocacy. There was, for a long time, and we still suffer from that, for a long time, there was friction between specialties. In most countries, they still fight whether the leader of the trauma team should be a general surgeon or an orthopedic surgeon or an anesthesiologist. In other countries, they fight whether, you know, this should be within the general surgeon's profile and why should they do it. So we consume ourselves in small politics in between us instead of looking at the bigger picture and advocating in governments about how important trauma is, and most importantly, how self-sufficient it is financially if we throw these injured patients back to society intact. Advocacy.
That was indeed very inspiring talk, oration, and it highlighted all the complexities of trauma and its care, prevention and care and rehabilitation. And you very aptly said, any one of us can be the victim as soon as we walk out of this hotel. And we have seen that happening. There was an industrialist not too long ago traveling on a highway in Maharashtra. His name was Cyrus Mistry. He was in a very expensive car. He crashed, he died. There was another industrialist, Indian industrialist in USA. His son was skiing somewhere and he met an accident, he died. This happened very recently. So these things do happen, but the point is we developed countries, as USA, North America, Europe, have done well in injury prevention also by enforcing the rule of law to a large extent. See, if I compare today injury in Europe, UK, USA, it will be maybe 3, 4 per 100,000. Despite that, you have more vehicles, you have more cars on the roads, much larger than what India has today. But what our problem is in India, we have close to 4.6 lakhs accidents per year, and we lose almost half of that. So in every accident there is a death. And the proportion, what somebody very aptly analyzed, then my probability of dying on an Indian road is 1 in 5, opposed to US, which is 1 in 69, and that is what you mentioned about trauma system. If you go back to 1979, when you compared trauma system in 2 counties, Orange County and some other county, where the trauma system was in place and the outcomes were different. What we have very difficult geography, the distances, So all that put together, even if somebody says that we get patient in 1.5 hours, is still early. What to talk of 6 minutes or 15 minutes? Because we get patients after 4 hours, not in villages, not in rural area, in city of Gurgaon. That's our problem. Patient goes to one hospital, to other hospital, to other hospital, and then lands up with some hospital who cares for that patient. And that is something which we are emphasizing, the golden hour concept, what trauma we have been following, that if we take care of the patient during that first hour after injury, naturally the outcomes would be obviously much improved. But what we emphasize in India, and this is for all emergency physicians sitting here, turn the first hour when you receive the patient in your emergency department as the golden hour. And we have seen that many patients with severest of injuries would be salvaged and returned functional and productive to society. So that is something, because we cannot change everything suddenly. And this is going to take time. Injury prevention, you see, even helmet enforcement, 72% of our automobiles on our roads are two-wheelers. They are not four wheels. And 50% of those who die, they are riding a two-wheeler in India. So there are issues, we can learn things from US, North American experience, from European experience, and then we have to evolve our strategies. And naturally, what you were in 1965 or 1976 or 79 when ATLS began, I think we are still, if quite not there, but close to there.
You need smart people here.
Yeah.
To create not only, I mean, we're all physicians and nurses. We all have good intentions. We want to fix society. There is one thing that we don't take into account with physicians and nurses: money. Money.
Absolutely.
It is, if we do not create financially good models in trauma, I mean, that's when America took the turn. Initially, we built the system and there was not a single hospital that wanted to become a trauma center because they were losing money. When the financial models changed and they were making money, now you have to throw a stone. If you throw a stone in America, you'll hit a trauma center because they all make money. So we need business savvy people, not the government, business savvy people to create good financial models that create profit. Otherwise, this world does not move in a different direction.
No, you are absolutely right. And that is where the most trauma in India happens to lower middle class or poor, economically backward people. And unfortunately, the private healthcare system is not yet ready to care for injured patients. Only those get treated who can afford, or they are covered with insurance. Majority of this trauma goes to public hospitals. Whatever they get it. So that is where we are. You are absolutely right, but we have to evolve a system where these patients can be treated in every hospital that efficiently, and that's why I appreciate Marengo Asia hospitals, where they have taken trauma as a leading point of discussion, unlike many others, because they only attract big ticket surgeries, transplant, cardiac surgery, arthroplasties and all, which can generate a lot of money. Thank you.
Sorry to interrupt, we are running out of time. With a closing remark, as a chairperson of the session, I would like to have some positive remark. Initially, there was a landmark judgment from Supreme Court of India before a few years. Initially, if somebody gets injured, the Good Samaritan who takes him to the hospital or her to the hospital would have a lot of questions from the police. That Supreme Court totally banned it. So it makes huge difference. Now, second big change has already come that I think that a lot of people are not aware of. Just before 3 days, the Prime Minister of India has declared 1.5 lakh rupees of the cost of the emergency admission or treatment would be borne by the government. So as you very rightly mentioned, it's all about money. This is going to make a huge difference, and I'm very positive when we meet next time with the efforts of Dr. Singhal, Dr. Velmahos and the government and all of us, we would have better future for the India. Thank you very much. I close the session. Thank you very much. Thanks a lot, doctor. Thank you very much. Very inspiring lecture. We like your passion more than you. Thank you.
May I please invite Dr. Richard Mitchell to join Dr. Rajiv Singhal in the center of the stage. May I also invite Mr. Ali Al-Qadi to please join the dignitaries on the dais. And may I request all of you to please stand in place for a standing ovation for the man of the hour, Dr. George Velmahos, please. A man as brilliant as he is kind. Could we have a thundering round of applause? Do we continue clapping, or would you like another dose of caffeine? Ladies and gentlemen, the most deserving recipient of the Marengo Asia Oration Award for 2026, Dr. George Velmahos. The Marengo Asia Oration for 2026. Ladies and gentlemen, a final round of applause for our brilliant speaker. May I request, yes. We would like to felicitate the chairs for the day. Dr. Jaideep Grover, Dr. Singhal. Dr. Singhal to do the honors, please. Dr. Jaideep Grover. I would also request Mr. Ali Al-Qadi to please felicitate Dr. K.C. Mehta. Yes. Mr. Al-Qadi would like to felicitate Professor George Velmahos with a token of his affection from the Kingdom of Saudi Arabia. Ladies and gentlemen, a thunderous round of applause one more time. Thank you so much for your kindness and your generous gesture. We are deeply honored to have you with us today, sir. And it is our absolute pleasure to have you felicitate Dr. George Velmahos again one more time. Should we all stand in place one more time as the dignitaries leave the dais? Thank you so much, ladies and gentlemen. It has been a truly memorable evening.